Thank you. As you can see from below on the screen, I was a specialist anesthesiologist. Well, I say was, I stopped doing it about 18 years ago and concentrated solely on management of chronic pain. Been doing that for 18 years. And somebody of your group got hold of my name somewhere and asked me to give a talk on the difference between, what is the difference between acute and chronic pain? Is there a difference? Well, we'll see that later on. Now, unfortunately, I don't know the audience here. I don't know who you guys are. So I don't want to get too technical and bore you, but I also don't want to insult you by dumbing it down too much. So I'm trying to go a good middle of the road. But in my experience of treating pain, and I see nobody takes chronic pain seriously. And by that, I mean everybody that doesn't have chronic pain. So the doctors don't take chronic pain seriously. They send the patient to the psychiatrists. The medical aides don't take it seriously. The family members of the guy with pain don't take it seriously. Nobody takes it seriously until they have it. Then it's a big issue. Then they want to see me immediately and soon. No, you didn't take it seriously. Somebody else wait your turn. No, I'm joking, but that's how it should be. So anyway, to getting on to pain and chronic pain. Well, yeah, you have this guy fighting a fire, and but there's a lot of smoke, and this smoke is going to cause even more damage maybe than the fire itself. The fire could be a localized thing. It looks like quite a serious fire. Maybe it's an oil container. If it's just that oil storage unit that's burning, but that smoke's going to do a lot more damage. So what's his options here? His options can be to get rid of the smoke. So, you know, you can try all various tricks to get rid of the smoke. But there's always going to be smoke. You're never going to get rid of that smoke as long as that fire is burning. So this fireman here has got the right idea. He is he's paying attention to the cause of the smoke. He's aiming his jet there at the cause of the smoke. He's not trying to deal with the smoke. That's going to do more damage. He's trying to eliminate the smoke by eliminating the cause of the smoke. And also, he must know what kind of fire that is before he tries to apply his treatment to this fire, because, you know, electrical fire, apparently you shouldn't put water on it, and another one you should put powder on it, and another one, oil fires, you shouldn't put water on it because you've got to do foam. So he's got to know what kind of fire this is before he can address the issue of the smoke. But until he puts the fire out, there will always be smoke. And that's the important thing here. And in treating pain, pain is a symptom, even chronic pain. It's the smoke of the fire that's burning. And everybody, and I mean almost everybody, spends all their efforts on pain management, treating the smoke, trying to treat the pain. If you kill the fire, the smoke goes away by itself. If you kill the cause of the pain goes away by itself too. But let's get into that. So chronic pain. Is there more to it than meets the eye? Well, before we find out if there is more to it than meets the eye, we have to decide what actually does meet the eye with chronic pain. And the answer is nothing. You know, nothing at all. Because it's purely subjective. Nobody can see your pain. It can be observed or measured. Somebody's got to take your word that you have pain. And most people are not very inclined to take your word that you have chronic pain, especially under certain circumstances. And so this leads many people to believe it doesn't even exist. Doctors I'm talking about, and family members, and whatever. This is all based on ignorance and lack of understanding of what pain and chronic pain is. Now, at medical school, we are taught that pain has an adaptive and survival purpose, and that is true. It's a symptom of an underlying condition, and once you've dealt with that underlying condition, the pain should go away. And this is true. Just like we saw the smoke and fire, the pain is there, deal with the underlying condition, the pain will go away. And it's also, but not always in chronic pain. That's the difference. Pain also serves as a warning. Hey, whatever you're doing now, cut it out because it's hurting. So stop it now. And when you've had an operation, the pain has the major factor of immobilizing you. You don't walk around on your newly operated leg. It immobilizes you and gives the body a chance to heal. So, therefore, pain management should be easy. And I write easy there like that sarcastically, because it's not that easy. But this is what people think. Pain management is easy. I mean, if the guy has pain, give him a pain tablet or an injection, or do some physio, or give him some psychology, or whatever. And if he's got stronger pain, give him a stronger analgesic. Or let's combine analgesics. Now, that's a good practice. I'm not knocking that, but that's an attempt to deal with the smoke. And then opiates, the strongest painkillers, well, we must avoid them at all costs because of addiction and respiratory depression. But and if you absolutely must use them the absolute minimum, to the point that they don't work, so why bother to give them? So, yeah, if this is so easy, pain management is so easy, why do we need a pain clinic or a pain specialist like myself? But if it really was this easy, as it says above there, then why have we all, doctors, associated health practitioners, whoever they are, physios, all sorts of therapists, why have we all seen patients with apparently unstoppable pain where no analgesics or amount of analgesia, or no analgesics or amount of analgesics work? Not even intrathecal morphine sometimes, or spinal cord stimulation. If this was so easy, why are there these patients running around who are claiming, well, sorry, they're not running around, they're rolling around in wheelchairs, most of them, and claiming that analgesics don't work for them? Come to that now. So we conclude an illogical explanation that they must be putting on. So where do they get sent? To the psychiatrists and the psychologists. So because the above management here of pain with analgesics and physio and all things, treating the smoke, not the cause of the pain, but we are treating the cause of the pain. Also, if you break your bones, they'll set it. It'll be painful until the thing is united and the pain will go away. But in the meantime, let's give him some pain medication to make him more comfortable. It's all true for acute pain, but not for chronic pain. Chronic pain is different. How? That's the subject of this talk. There's a difference. Well, it also has the same things as the acute pain. It's also a symptom of an underlying condition, chronic pain. And the pain will also go away once you've dealt with the chronic issue causing the pain, if you can. It's hard to deal with arthritis. Well, so much so that we go to replace the joints. It also serves as a warning, and it can also immobilize you, but not for healing. Just immobilize you because it's too painful to move. So the concept that pain is pain and acute pain and chronic pain are the same thing. They are not. In other words, people believe that acute pain, chronic pain is simply acute pain that is lasting too long. But that's old and wrong. There's better up to. So in the British Medical Journal 2016, these three very clever ladies from those places, and they said, our mistake is to treat chronic pain as if it were acute or end-of-life pain. Now, end-of-life pain is a wholly different thing. We've got acute and chronic and end-of-life pain. You treat that completely different to any of the others. Right, so this misconception that pain is pain leads to general misunderstanding of what chronic pain is. It's a pathology, not only a symptom. I'll explain myself later on. An inadequate and inappropriate treatment of the pain, this is what leads to, because people try to treat chronic pain as if it were acute pain. Wrong. So they get the incorrect medication. The medication dose escalates to overdosing. Unnecessary special investigations. I've seen patients come, they have an MRI, and they go to the next doctor, and he does another MRI, and he goes to the next doctor, does an MRI, and they come in there with all the MRIs in a wheelbarrow because they're too heavy to carry. And nobody's found anything. And these unnecessary surgeries or repeat surgery, especially spine surgery. And these are all attempts to treat chronic pain the same way as acute pain. And so this misconception leads to general neglect of these patients because the doctor just doesn't know what to do anymore. The physio can't help the patient. All the other therapists can't help the patient. But we don't, so we decide to not admit that we don't know. We'll just pretend it doesn't exist and hope the patient will just eventually go away. And the patients get told it's in their head. So they get sent to the psychiatrist or the psychologists. And here's the kicker, I see this a lot. Patients get told they must go to the psychologist or the psychiatrist because they will teach you to live with it. Or they will make pain, you'll teach you how to make pain your friend. And that sounds ridiculous, but it happens in my practice on a weekly basis. Oh, I've been to the psychologist. Oh, he didn't help me make pain, my friend. I've been to the psychiatrist. He didn't teach me how to live with it. I've still got pain. And the worst of all is they get accused of having compensitis. That's a very belittling term that doctors have for patients that, oh, he's just pretending he has pain to get compensation. So there are two kinds of pain, acute pain and chronic pain. But to complicate this, there's just two kinds that each can be classified as either nociceptive pain, this is stimulation of nociceptors, or neuropathic pain, which is from sick nerves. And acute pain and chronic pain are only the same here, that they both have nociceptive stimulation. So let's talk nociceptive pain. You can see in the bottom right-hand corner, I don't know if you can see my arrow working there. You have the nociceptors, which are receptors in all the organs, especially the skin. And you have one neuron taking the pain from there to the dorsal horn of the spinal cord, where they have a synapse. Synapse, for those who don't know, as again, I don't know who my audience is here, where two nerves connect. There's a gap, and the one impulse comes down the one nerve, jumps the gap, and then promulgates down the other one. And then you've got one neuron from there to there, one neuron from there to the hypothalamus, which is the emotional center. So pain has an emotional element, definitely. And then from there to the, now this doesn't want to go to there, from there up to the cortex, the brown one, where we can become aware of pain and can localize it. So there's three nerves involved, getting pain from wherever it's happening to the brain, three neurons involved. Right. So what is a synapse quickly? A synapse is between two neurons. The impulse comes down the one neuron, liberates the chemicals, the neurotransmitters, which then diffuse across the membrane, the gap, and then stimulate this one, and the impulse continues. Very important for later on when we talk of chronic pain. Right. But let's go back to the nociceptors. What are the nociceptors? Well, in all our tissues, especially the skin, we have various receptors for various sensations. Here we've got a little thing around the hair follicle, which senses touch, obviously. And then there's other one also, Meckel's disc and whatever, that senses also tactile. Well, I just want to see what. And then, yeah, at the bottom we've got these ones that sense pressure and vibration. These are the Pacinian corpuscles. Here we have it also, Marshall's corpuscle, tactile, touch, and then these free nerve endings. These are the nociceptors. They pick up touch and temperature and pain. You can see that the only ones that really pick up pain. And so these are the free nerve endings. These are known as the nociceptors. These are the pain receptors. No chi in Latin is bad. So these are the bad receptors because they sense the bad things. They're a specific type of sensory receptors picking up pain. So if we go back to a nociceptive pain, this is pain with a cause. It's pain that is coming from the nociceptors. So if you pinch yourself or burn yourself or cut yourself on the skin, you feel the pain because you stimulate the nociceptors and your brain says, okay, there's pain happening in that area of the body. So pain due to inflammation, limb pain after a fracture, joint pain, osteoarthritis, chronic pain can also be nociceptive, cuts, pitching, burns, stabs, etc. This is nociceptive pain. Common descriptors are aching, throbbing, stinging, burning, and typically localized to the site of injury, usually time limited when the condition that's stimulating the nociceptors goes away. Could be somebody pinching you, or could be a bone fracture. When that goes away, the pain goes away. And here's the important thing, they respond to conventional analgesics. And that's all conventional analgesics were designed and made for, is treating nociceptive pain. But not all pain is nociceptive, as we shall see. So both acute pain and chronic pain have a nociceptive element, but then both pains, acute pain can be neuropathic and chronic pain can also be neuropathic. What is this about neuropathic pain? That comes from the sick nerves, and it is initiated by primarily in the peripheral or central nervous system, not just the nerves outside the spinal cord. You can have neuropathic pain, especially from the spinal cord. A little bit from brain, if you have a stroke or some problem in the brain, can give you pain in the rest of the body too, but mostly spinal cord, not just peripheral nerves. So when the nerves become damaged or sick, they stop working properly. And this can be to an immune reaction due to nerve injury. If you injure a peripheral nerve anywhere in the periphery, you'll get inflammation in the spinal cord. That's your basis of phantom pain. Guy's leg has been lost. That nerve to the foot has been cut off and thrown away. But you still get pain in that foot. Why? Because it now gets inflammation in the spinal cord, which irritates that first synapse there, and that starts firing up to the brain, and the brain says, oh, this impulse coming from that nerve that goes to the toe. Even though there's no toe, the brain registers pain in the toe that's not there. That's the basis of phantom pain. So these nerves become super sensitive and overactive, and they send inappropriate signals to the brain. Injury in the nerve may tell you the foot is burning, even when you don't have a foot. Okay. So neuropathic pain is mostly chronic. There's only one real acute neuropathic pain, because even if it's a nerve injury, it takes a while to develop after the neuropathic pain. But acute shingles, anybody that's had shingles knows that it's exquisitely painful. And it's a neuropathic pain, got all the symptoms and signs of neuropathic pain. And it's acute, and it goes away once that virus goes away again. And of course, phantom pain, as we've discussed. Post-herpes neuralgia. Well, here's the thing. Sometimes the acute shingles it goes away, and the virus has gone away, but the nerve has been damaged by the virus, and the pain stays. And you've got post-herpetic neuralgia, diabetic peripheral neuropathy, trigeminal neuralgia, post-surgical neuropathy. These are all chronic pain states, but chronic neuropathic pain states. Common descriptors, burning. If the patient says my whatever is burning, be rest assured it's neuropathic pain. Stabbing, tingling, radiating, or hypersensitivity to touch. Most importantly, we call it allodynia. Something that is normally pleasant is terribly irritating or sensitive. That's allodynia. And here's the big kicker. Where nociceptive pain is receptive to common conventional analgesics, neuropathic pain is not. You can pump this patient full of whatever you like. Panado, morphine, anti-inflammatories, ibuprofen, whatever you want, put him full of it. Take his opiates up to where he is almost in a coma, he will still have pain. It doesn't respond to normal. Then those patients get told, put it in your head, you need to go and see a psychologist. It's not. And it can be in the distribution of a specific nerve, if it's just one nerve, that a mononeuropathy, if one nerve was damaged in an injury or an accident or by shingles. But now we have even something a little bit more complicated, and this is where chronic pain comes in. So you have your nociceptive pain and your neuropathic pain. Well, that was supposed to. I can have mixed pain, like osteoarthritis pain. You have pain in the joint. The joint is degenerating. That's nociceptive pain. But why has it been found that you can do a lot to relieve osteoarthritis of the knee by giving them a certain, not all and not any, a certain antidepressant, duloxetine? Because suddenly that acute arthritis, that chronic arthritis has got a neuropathic component as well, not just nociceptive. So, we asked the question at the beginning, is there more to meet the eye, etc.? So in spite of the fact that it cannot be seen, and it's purely subjective, and lots of people don't believe it exists, it does exist. And it exists as a pathology, not just as a symptom. So what is this pathology then? I've tried to not make this too technical, but let's see as we go along. Is pain a pathology and itself and not a symptom? Well, the pathology of chronic pain consists of altered, facilitated pain processing in the spinal cord, in that dorsal horn, where the first synapses, remember I said that synapse is going to be important with the chronic pain. It's there that this happens. So, sensitization of that first synapse in this, where the nerve comes in the dorsal horn. And as we discussed there, the phantom pain, when that area gets irritated with inflammation due to the injury to the peripheral nerve, you get all this facilitation of pain processing going up there. So that synapse in the dorsal horn can become sensitized. And this area here is where chronic pain lives. Phantom pain lives here. Chronic pain lives there too. Right. What do I mean by wind-up or central sensitization? Physical changes. Physical changes in the dorsal horn. The dorsal horn. Physical changes take place there, which lead to altered pain processing here in the dorsal horn. And that leads to facilitated pain transmission. Now, we've all heard of the pain gate, mostly heard information wrong, but we all know that there's some sort of a gate for pain. And when it becomes wound up or sensitized, pain gate is open, and pain then has free access to the brain. There's nothing gating it out. And even origination of new pain impulses, as with phantom pain. So, how does this work? How does the chronic pain become neuropathic pain? And in the corner, I've said, very important, I think this is the most important slide of this whole talk. Chronic pain, whatever the origin, it could be due to nociceptive pain, that is pain that is caused from the nociceptors, a symptom. If it carries on and carries on and carries on and carries on, And very often due to inadequately treated acute pain, post-surgical pain, a lot of our chronic pain we see because the patient's pain after the operation was not adequately managed. And the spinal cord gets bombarded by pain impulses coming in all the time. And then neuropathic pain, as we said, immune reaction due to nerve injury and neuroinflammation. Both of these have led to altered pain processing in the dorsal horn of the spinal cord, as mentioned, or in the brain, due to physical changes there, giving both types of chronic pain a neuropathic element. So no matter if you've got arthritis in your knee, that's a nociceptive pain. The knee is degenerating. It still has a neuropathic element in the spine. And this is why you will see, I see in my practice, patients who have had wonderfully successful knee replacement, but they still have pain. And then the surgeon says, and spine surgery, of course. And the surgeon says, correctly so, my operation is perfect. There's no reason for you to have pain. Yes, there is. It's the neuropathic element now in his spinal cord. So in spite of your perfect operation, there is still this neuropathic element, sensitization of the dorsal horn in the spinal cord. That will give you persistent pain after your operation. So this makes a big difference to our treatment of chronic pain. This altered pain processing is what we call the wind-up or central sensitization. It's the pathology of chronic pain. So this is about the dorsal horn, where the spinal nerve comes in, and that's where chronic pain lives in the dorsal horn of the spinal cord. Okay. Most physical changes of central sensitization take place here in the dorsal horn. But what can cause, how much time do I have? Sorry. Anybody tell me? Okay. How does the central horn become sensitized? 3 ways. And the most important way is what we call the NMDA receptors. Again, I don't want to go into too much detail, but afferent bombardment. NMDA are receptors on the pain fibers, and from continuous hammering on this, you know, if a bull kicks on a gate long enough, that gate's going to give in. And having this afferent bombardment of untreated pain, it could be pain from your knee joint, it could be pain from your spine, it could be pain from your bunions, it could be all these pain are hammering on the spinal cord, causing sensitization of the dorsal horn. The other one is interneurons. This is the pain gate. This is where the constant hammering of the afferent bombardment kills the little neurons that are the pain gate, and there's no pain gate. And then, of course, this is just an example of that. The pain gate is between the 2 neurons, and if you take away that activity in this synapse, in this neuron, through this little interneuron, will block the pain, the C fibers. However, if this little neuron is gone from constant hammering, it will go away. And then this pain, nothing blocks it, has free access to the brain, where we all become aware of it. And then acute immune response. And this can be due to any neuroinflammation. And we've heard the previous talk about inflammatory foods, and that is a definite part of it, but there's more to it than that. As far as this is concerned, as I say, an injured nerve will give you an immune response in the spinal cord, giving you neuroinflammation. So if you want to treat chronic pain adequately, you've got, sorry, this is just showing you that the microglia, which are the inflammatory cells in the spinal cord, secrete a lot of substances which sensitize the synapse, which facilitates the transmit or increases the amount of neurotransmitter, which gives a bigger impulse down there. So it winds itself up and gets chronically more and more difficult to treat. And so the sensitized or overactive pain system due to neuroinflammation. The neuroinflammation can be from too much inflammation in your body in general, an inflammatory diet, but also due to the gut microbiome not being healthy, and the lack of butyrate in the body. This is all another topic on its own. So, long-standing pain. And this is why there's a definition of chronic pain being about 3 months, because you can have all this, and if it's there for 3 or 4 weeks, it'll go away. But once it gets to about 3 months, it starts becoming a very difficult thing to treat. Because you now have this mixed pain, you have nociceptive pain, which gives rise, because of constant hammering, gives rise to the neuropathic pain, and this gives you rise to this mixed pain. And so your treatment must be not just nociceptive, not just treating the smoke. You've got to go and treat the neuropathic element as well. And here we have osteoarthritis. You know, I was asked if I was bringing this specific to spondylitis. Let's bring it here to spondylitis. What is spondylitis? Inflammation, degeneration of the facet joints. And how can we get rid of that neuropathic part of spondylitis? Well, we as, sorry, no, I thought it was the next one. We as pain, especially we're going to do rhizotomies to kill the nerve to the joint. But that is not always successful. Why? Is it a bad procedure? No. Is it badly performed? Maybe. But why can you treat it and denervate those joints, but still have pain? Because of the long-standing pain, hammering on the spinal cord. There's now a neuropathic element in the spinal cord that also needs attention. So what is chronic pain? Then it is not simply a system of another underlying condition. It is a medical entity and condition in its own right. It is not protective like acute pain, does not serve as a warning of an underlying condition, and it is destructive, serving no purpose, and unlike at all like chronic pain and like acute pain, sorry, it is serves no purpose like acute pain does, and it is completely disabling. When people get pushed into the consulting room and they're in a wheelchair and say, "What happened to you? Why are you paralyzed?" I'm not paralyzed, I just can't walk from the pain. That's disabling. Okay. So, if we're going to be the fireman, the healthcare practitioner, we have to give attention to the cause of the smoke, which is now, in our case, we know the pain. What's the cause? But we must know what kind of fire we're dealing with. Are we dealing with a nociceptive pain only? Or once we've dealt with that, is the pain continuing? Do we send him to the psychologist? Or do we treat the neuropathic element of his pain? So we have to know what we're dealing with in order to treat it correctly. And so what is the correct treatment? Well, first of all, treat the nociceptive element. Get rid of that nociceptive pain. And in case of spondylitis, do a rhizotomy. Or in the big joints, do a joint replacement. Or whatever you have to do to get rid of the nociceptive part of the pain. And then you treat the neuropathic element, and there are different ways of doing that. I can't give you a whole talk about the treating of the neuropathic element, but inflammation plays a major role in that. And then you can treat some other of the smoke. In other words, you treat the muscle spasm when you've done those. You know, people often say to me, say, "What's your diagnosis?" "No, I've been told I have muscle spasm." "Yeah? Why?" "No, I don't know, I have muscle spasm." Muscle spasm is not a diagnosis. Stop trying to treat it. Muscles don't get together and say, "Oh, let's all go into spasm today. We've got nothing else to do." There's something making them go into spasm. And that spasm will never be dealt with until you deal with the cause of the spasm. And once you've treated the nociceptive elements, and the neuropathic element, then you can treat the muscle spasm, and the muscle spasm will most probably then go away. And so the treatment of chronic pain is not the same as acute pain, and it's definitely not just acute pain lasting too long.
Sorry, Dr. Raath.
Thank you. Yeah, that's done.
Oh, is that everything? Okay, perfect.